I'm Wing Commander Dr. Tahira Sadiq, and today I'm going to discuss about influence of pregnancy complications on long-term cardiovascular health in women. Thank you, Madam Nusrat, and I also thank Professor Khalda to arrange always the go-red session in the conferences. All right, so this is PF Hospital where I work, and recently I'm promoted to Wing Commander. So, ma'am, this is the new news. Yes, ma'am. All right, so we all know that incidence of heart disease is on rise, and definitely it's not only in rise in men, it is also on rise in women. And the rheumatic heart disease incidence is decreasing in developing as well as in developed countries. But the pregnancy with heart disease has increased. And let me tell you one very important thing which I just noticed in Dr. Shoaib Nisa presentation, that I think the decade of life in which the female get pregnant has changed. I saw that the women are now presenting with pregnancy and heart disease in the age group from 30 to 40. Seeing more pregnancy with heart disease. There are many hemodynamic changes which we see in normal pregnancy. The plasma volume is on rise almost 40%, and the cardiac output, it also increases, heart rate increases, and the systemic vascular resistance decreases. The pulmonary vascular resistance also decreases. So there are many critical periods of pregnancy. The initial first 6 weeks and the maximum changes are around 30 weeks. And intrapartum period, just after the delivery, the postpartum periods, these are all very critical periods. So the pregnancy changes, all of these changes which I mentioned, they mimic the cardiac diseases. Because of these symptoms, patient develops breathlessness, weakness, edema, syncope, tachycardia, and you can even hear a small murmur, a systolic murmur, and displacement of apex beat is due to the presence of fetus. So the symptoms of heart disease, they also are same. You can see the progressive dyspnea, nocturnal cough, syncope, and chest pain. So that is why it's very important to see a pregnant lady very carefully. What are the red flags during pregnancy? Cyanosis, clubbing of fingers, persistent distended neck veins, diastolic murmur, cardiomegaly, these are all red flags. And if you see these signs of heart diseases, then you should be looking after that patient, and every gynecologist, if she sees such symptoms, should refer the patient to cardiologist. And the investigations, if you see any arrhythmia, hypertrophy changes in ECG, or you see any cardiac defect, congenital heart disease in echo, or you see any cardiomegaly in the previous x-rays, then you have to investigate those patients further. We can classify heart diseases in pregnancy according to the etiology into the 4 main groups. The congenital heart disease, which are non-cyanotic, like AST, VST, PS, and coarctation of aorta, and rheumatic heart disease, which are the acquired heart diseases, mitral stenosis, mitral regurg, aortic stenosis, aortic regurg, and we all know that rheumatic heart disease makes a big chunk in the pregnancy and heart diseases. Cardiomyopathies, ischemic heart disease, and some conduction defects. So there is a risk classification according to the risk. We can classify it into low risk, in which 0 to 1% risk is seen in patients with AST, VST, PDA, and corrected fellow of tetralogy. And medium risk is 5 to 15% in patients with mitral stenosis, which is mild, or mitral stenosis with AF, aortic stenosis again mild, and uncorrected fellow of tetralogy. Remember that pulmonary hypertension is the only condition which is high risk, very high risk. 25 to 50% maternal mortality is associated with pulmonary hypertension. Again, Eisenmenger syndrome, aortic coarctation with valvular involvement, and Marfan syndrome with aortic involvement. So what are the poor prognostic indicators? If you see the patient is having heart failure symptoms, TIA or stroke, arrhythmia, pulmonary hypertension, or the baseline NYHA classification was 3 or 4, that is the patient was very breathless even before pregnancy, or the mitral valve area is below 2 centimeters square, or aortic valve area below 1.5, or the EF was before pregnancy 40%. These are all very poor prognostic indicators. There are some additional risk factors which add on to the complications. These are anemia, infection, hypertension, or physical labor, weight gain, multiple pregnancies, or the use of alcohol or drugs like glucolysis. It also is an additional risk factor. So what are the effects of pregnancy on heart diseases? A patient who is pregnant and having already with a congenital heart defect, pregnancy can lead to the worsening of the cardiac status. It can lead to cardiac failure. Patient is prone to bacterial endocarditis, and if she is a patient of Marfan, then there could be the rupture of aneurysm or aortic dissection. And there is no long-term effect on the basic defect, but the cardiac status can get worsened. And what heart disease do with the patient and the pregnancy? They can lead to abortions, they can lead to IUGR, preterm labor, and congenital heart defect in baby to a pregnant lady with a congenital heart defect is 5%. IUD is also one of the very depressing condition for a lady and the family. Now, I'm going to discuss a very important the research study which I found, and it was published in JACC, and it was an original research article, long-term cardiovascular complication after pregnancy in women with heart disease. Almost 1,014 females were included in this study, and these were the females with pregnancy and heart disease, and they were followed in long term. They were followed up to 20 years. And it was noticed that pregnancy, you can see in this graph, that pregnancy with low risk pose very good outcomes, and if you follow those patients to 20 years, development of long-term cardiovascular outcomes is seen in almost 3% of the patient, and the pregnancy with intermediate to high risk has cumulative incidence of events much higher in this group. It was almost 30%. So the conclusion of this study was that pregnancy with heart disease leads to long-term cardiovascular complications, and it also includes development of long-term hypertension and diabetes. One very important message from this study was that we can use the risk assessment tools. CARPREG and WHO risk assessment tools should be used in pregnancy with heart disease. This is another study, and it was our local study by NICBD, and it was published in Journal of Pregnancy and Child Health. So this study was concluded that hypertension in patients with history of hypertension disease of pregnancy and without history of hypertension disease of pregnancy were 88% versus 82%. So there was 8% increase in the development of long-term hypertension. And it was also observed during this study that 1/3 of patients who presented with ACS were having hypertensive disease of pregnancy. So how to manage these patients? How to manage a pregnant patient with heart disease? You have to be having a high risk index of suspicion, and they need to be timely diagnosed, and there should be a very effective management plan, and it is always a teamwork. The team should consist of obstetrician, cardiologist, anesthetist, and neurologist, cardiothoracic surgeon, and good nursing staff. The pre-conceptual counseling is very important. I think many of us see pregnant ladies, like Dr. Sadiq was mentioning, that patient with Eisenmenger, they come to you. If they come to you early, you have to counsel them for termination of pregnancy. And uh, I must tell you that it is very important, but at the same time, very difficult time for the family to tell them about the termination of pregnancy. So you have to discuss about maternal and fetal risk. You have to tell them about the prognosis of that pregnancy, and social and cost constraints, you have to consider them. Then hospital delivery should be at a tertiary cardiac setup. Medical termination of pregnancy is indicated in high-risk patients or the patients with red flag, as we previously discussed. The patients with Eisenmenger syndrome, they need to be terminated at an early stage. And usually it should be done at the first trimester and before 8 weeks. Suction evacuation is the preferred method. And we have to carry it in mind that it also carries the risk for life. So, good antenatal care, the antenatal clinic checkups are recommended to be every 2 weeks up to 30 weeks, and then weekly in the last trimester. And you have to ensure the treatment given to the patient. The fetal echo should be done for anomaly scan at 20 weeks. Fetal monitoring is also very important. Then there are some special advices which you have to give to your patient. You have to tell them about maintaining a good hygiene, good dental care, and dietary salt restriction is really required. It shouldn't be more than 4 to 6 grams per day. You have to tell your patients to avoid smoking, and you have to identify early red flags. There are some indication of admissions. You have to admit the patient whenever there is heart failure signs, and subacute bacterial endocarditis prophylaxis is given to the patients with congenital defects. And you have to look after these patients even after discharge and even after they are delivered. Contraception is very important in all these patients. So the conclusion is that women with heart diseases are at high risk for adverse long-term cardiovascular outcomes, including the development of new hypertension and diabetes mellitus. And the tools, CARPREG and WHO risk assessment tools should be used. So this is our responsibility to take care of these pregnant ladies. Thank you.
Tahira, thank you so much. Dr.